All right, good morning, everybody. It's just gone 8:05, so I think it's best to get things started, kick things off. So I'm very excited to welcome Dr. Somaroo and Mr. Nkosi from the Department of Health to this morning's academic meeting. For some background to those joining us from other universities, thank you for joining us. Charlotte Macheka, Johannesburg Academic Hospital, runs our academic meeting from 8 to 9 every Friday morning. We have about 40 slots in the year, and it's hosted in person and online. So if you're interested in joining, when you sign the CPD link at the end, there will be an option to say, are you happy for us to add you to our mailing list? In which case we are happy to do that. And also just on that note, welcome to colleagues from other hospitals within the Wits circuit. We often work independently, but we all work together most of the time. So the topic of this morning's meeting, it is an ethics talk, but it's about NHI and central hospitals and how NHI will really affect academics. It was a discussion that started with Professor Nicholas Crisp a few months ago, just saying, what effect would the NHI have once it does come into place on academia and what we then said academic hospitals. And just as a note for everyone, in the National Health Act, there's no such thing as an academic hospital. Instead, there's tertiary and central hospitals, and obviously secondary hospitals that are attached to academic units. So on that note, I think let's get things started. So our speaker this morning is Dr. Harsha Somaroo. Dr. Somaroo is a public health medicine specialist who has a background in clinical care, HIV research, health management, and public health. She is currently employed as a public health medicine specialist at the NHI branch of the National Department of Health in the Healthcare Benefits and Provider Payment Directorate. She has a long CV, which also includes being the immediate past president of the Public Health Association of South Africa. And she is also a member of the College of Public Health Medicine at the college, and she chairs the Public Health Medicine Curriculum and Assessment Practices Subcommittee, and also serves as a board member of the Global Climate Health Alliance. So we're really happy to have Dr. Somaroo here, and we're really grateful that you could join us this morning. Our panelist this morning, who I don't think has managed to sign on yet, but I'll introduce him anyway, is Mr. Moremi Nkosi. Mr. Nkosi is a health economist by training, and his areas of interest include health equity and health system strengthening. So he's been involved in the policy and legislative processes around NHI since joining the Department of Health in December 2007. He's currently the Chief Director for Healthcare Benefits and Provider Payment Design, and he's part of the broader team in the department's NHI branch working on the establishment of the NHI fund and its related structures. Just some housekeeping rules. You will not be able to unmute yourself or turn on your video. If you have any questions, I ask you to please post them in the chat, in the Q&A at the bottom. You can post them in the chat if you want to, but the Q&A is better. And we'll make sure there's enough time for questions. I'm sure this is a burning issue in everyone's mind. But on that note, I'm going to stop talking and hand over to Dr. Somaroo.
Okay, thanks, Jarrod. And again, good morning, everyone. It's a pleasure to be here with you to talk about the NHI. And Jarrod, based on some of the email discussions, I thought I'd basically go through an overview of what's in the NHI Act, and then we'll have some time for questions as well. So I think hopefully some of the questions will be addressed in the content that's shared, and we can also have discussions afterward as well. So I think to start off with, it's always important to place where we're at. Why are we actually embarking on an NHI reform, and what do we really need to fix in the country? I think many of us might be familiar with some of the slides and some of the data, but we know that South Africa has a very inequitable healthcare system. I think, and what we've seen is that over the past 15 years, this inequity has become more entrenched. I think everybody also knows about the differences between the public and the private healthcare sectors, and I think each sector is plagued by its own challenges. What is important in terms of healthcare spending is that more money is being spent in the private sector on a very small proportion of the population compared to the public sector. And so if we look at this graph, we can see that there was linear increases in spending in both sectors until about 2021, where spending in the private sector has continued along this trend, but spending in the private sector has decreased. And I think many people are also aware of the fact that more money is spent in the private healthcare sector. 51% of healthcare spending in South Africa compared to 49% in the public sector. And the important thing, or the critical point, is that the 51% is spent on a smaller proportion of the population. In 2021, 2022, this would have been around about 14% of the population. So from the time the NHI Green Paper was released in 2011, where there were estimates of about 20% of the population being serviced in the private sector, this has decreased over time to 14% because of the increase in cost and the inaffordability of healthcare in the private sector. So if we consider the amounts spent, overall, the country is spending approximately 550 billion on healthcare per annum, with 51% of this in the private sector. I'm not going to go through these slides in details, but it's really a lot of the detail to the background of the spending. So when we look at what's being spent in the public healthcare sector, we've got majority of spending within provincial departments of health, and this really is for eventually impacts direct service delivery. Then you've also got funds at the national level, but a lot of this is directed to the provinces and districts. Then we've got health spending in defense, correctional services, local government, then workmen's compensation and the road accident fund. When we look at the private sector, here we're considering how money is spent, and we can see that 83%, majority of the spending, is from medical aid schemes, and approximately 14% is out-of-pocket expenses. What's concerning is that of this 14% that's out-of-pocket expenses, in the past few years, there's been an increasing trend where this money is actually due to top-up fees because medical schemes do not cover the full cost of healthcare services. Okay, then there's also medical insurances and private employer-based spending. Here, I'm not going to go through the graphs, but just to say that when we look at the per capita spending, so that's the money spent per individual on healthcare per annum. In the private sector, this is 5 times what is spent on a patient in the public sector. Okay. Then to look at the medical aid scheme environment, at the start of this year, there were 73 schemes in the country that were offering 311 options. And I think many of us understand these schemes. Many of us belong to these schemes, and we have different options. And what we know is that with these 311 options, not all of them offer comprehensive healthcare coverage for an individual. Then looking at the administrative costs of maintaining these schemes, I think when you look at the principal officer costs, it amounts to almost 140 million per annum. And the gross overall administration of fees amounts to about 21 billion. So there's a lot of money circulating within the healthcare environment and being spent via medical aid schemes in the country. And one of the goals of the NHI fund is really to redirect the spending so that it can cover more people at a more efficient, in a more efficient manner. So this is just basically talking to the schemes again. There's different types of schemes. You have restricted medical schemes that are where you're only entitled to be a member if you belong to a specific group, for example, a specific employment agency or a company. And there's 55 of these restricted schemes in the country, and they have 147 options. Of the individual 55 schemes, some of them have as many as 10 options. Then we also have what are open schemes, where any member of the public can join. And here as well, we can see that the different schemes have varied numbers of options. They also have efficiency discounted options, which are lower premiums, but when you consider what is covered, it does not cover the comprehensive basic packages of care. Obviously, the more you pay, the more services you are entitled to. So in essence, I think we've reached a point where we understand the inequity in terms of access to resources in the country. Majority of the funding is concentrated in the private sector. Also, majority of the healthcare resources, healthcare workers are found in the private sector as well. There's also intra and inter-provincial inequity in terms of allocation, and in terms of quality, there is massive disharmony. I think we're all aware of that, especially working in the public sector as well. So what the fund is hoping to do is really influence a change by funding for healthcare for all citizens in the public and the private sector. So somebody will be entitled to care in any healthcare environment, not based on the ability to pay, but on their healthcare needs. Okay, so I think we understand the inequity in terms of the spending and the different spendings in both sectors. And so in terms of the principles of the NHI, they really are looking to fund, firstly, at a primary healthcare level based on outcomes. At the primary healthcare level, they look to implement a capitation model to ensure the efficient uses of funds. Also, the goal is to integrate public and private resources to care for all citizens in the country equally, and then to introduce gatekeeping mechanisms to manage access to hospitals and specialist services like at the central hospital level. Okay, so I think we know we've been on a journey in terms of the legislative processes for NHI. It started with the publishing of the Green Paper in 2011, then the policy, then the bill, then the B-bill, and finally the president assented to the act in May 2024. So there's been a lot that's been happening since then, and I think there's been a lot of expectation now that the act is passed about what's going to happen and when it's going to happen. And I think hopefully in this presentation, you'll get a sense of the next part of the journey that will evolve now that the act is in place. So just to talk about national health insurance itself, this is a health financing system, and it's important to distinguish the health financing system from the entire health system overall. In terms of the health system and the governance of the health system, this will still fall under the National Department of Health for the public sector facilities. And the National Health Insurance Fund will fund personal health care services, be it in the public or the private healthcare sector. I think NHI aims to achieve universal healthcare coverage, and this is the goal of all countries in accordance with the Sustainable Development Goals. And what this means is that we're hoping for all people to get the healthcare that they need, when they need it, where they need it, and without incurring financial hardship. And you may be familiar with this UHC cube that really speaks about the different dimensions of universal healthcare coverage. And first, we need to speak about who should be covered, what services should be provided, and also how is the cost going to be borne. And so in terms of the population, the entire population will be covered, and the services will be determined based on a benefits package. So it's basically going to be, in essence, one big medical aid package, but for the entire country. And in terms of the funding, I think there's going to be different funding models at different levels. At the primary healthcare level, funding will be via the capitation model, where providers will be paid for the population that they serve, as opposed for individuals. At the hospital level, in the Act, it speaks about DRGs, which are diagnostic-related groups, and funding of these, as well as global budgets for more specialized services. as much as all of this is listed in the Act, the detail is not available yet because regulations still need to be written. Okay, then eventually the fund is going to, right now we have the NHI branch, it sits under the National Department of Health, and this was established before the NHI Act was passed, just to put systems in place to enable planning to happen. Obviously, this is a major reform, and so planning can't just happen once the Act is passed. Different systems need to be put into place prior to that. So the NHI branch was established, I think, 3 years ago within the National Department of Health. Eventually, once all the different regulations are passed, the fund will be a Section 3A public entity. So this means it will have its own board and its own administration, and it will not be part of the public services. So it will be separate from the healthcare system. Okay, and so what the fund aims to do is really to establish a purchaser-provider split. Basically, the NHI fund will pool all the health resources into one NHI fund and will purchase healthcare services for individuals from both the public as well as the private sector. And the fund will also contract directly with the service providers. So the fund will contract directly with the hospitals as opposed to the province. And all users, that's all people in the country, must register with a primary healthcare facility, that would be a clinic or a family practitioner, to be eligible to receive services within the fund. And so in terms of the purchaser, this will be the NHI fund for now. And eventually, once the NHI fund is fully established, medical schemes will also be allowed to purchase services on behalf of people, but they will only be allowed to purchase services that are not part of the benefits package. And then what we've listed here is just all the sections in the Act that relate to establishment of the fund. And then the next important consideration is providers, and the providers will be the different facilities within the public and the private healthcare sector. And what's important for service providers, be it at the primary healthcare or the hospital platform, is to be accredited with the fund. And accreditation is more than just certification with the OHSC. Certification with the OHSC is the first part of accreditation, and then there's about 5 other requirements that need to be met. And these include adhering to the benefits package of the fund, adhering to the pricing mechanisms, ensuring that the information systems are interoperable with the information systems of the fund so that information can be shared, ensuring that there's the right mix of healthcare professionals within the services, as well as ensuring adherence to the guidelines. Okay, then in terms of the funding models as well, I think specifically for the hospital level, this is currently being planned. And in addition to the funding models, there's also going to be pay for performance. So there's going to be performance incentives that will be embedded into the contracts. I think at this point in time, it's difficult to see how that will emerge because the information systems that we have are not at the level required to monitor services adequately. But over the next few years, hopefully work will be done to get these to the stage where they can monitor performance, and then the pay for performance systems and working in terms of monitoring health outcomes will be much more feasible. Okay, so in terms of the current processes for the NHI fund, Section 57 of the Act talks about a transitional phase. And this is divided into 2 phases. Phase 1, which was running from 2023 to 2025, and phase 2 from 2026 to 2028. So these are the timelines that are stated in the Act, but depending on the timing of the different processes, it may take longer or shorter than envisaged. So in phase one, the plan is for there to be focused efforts on health system strengthening initiatives to make sure that facilities do reach a point where they can be accredited with the fund. In terms of sometimes people feel that this may introduce an element of inequity because we know that some of the facilities, especially in the public healthcare sector, are not at the required level yet. And so there's a 5-year plan in place for facilities to be allowed to accredit with the fund and to work up to the required level, but they will have to show incremental improvement over the 5 years to remain accredited. Then in phase one, there needs to be establishment of the fund itself. So there's going to be regulations written to establish the governance structures, including the board and its committees. There will be amendments to other legislation that to allow what's in the Act to be implemented. Eventually, the NHI fund will be established as an independent public entity, and there will be a phase of purchasing personal health care services for vulnerable groups initially. And I think this will start at the primary healthcare level, but it will move on to higher levels as well. Phase two aims to continue the health system strengthening initiatives, as well as contract healthcare services from private providers. And then, of course, mobilize necessary resources. Okay, so this is what I presented now was a summary of the phases in section 57, subsection 4 of the Act. And I'm just going to go into a little bit more detail just to talk about the practical steps that are happening on the ground or will happen over time. So in terms of central hospitals, these will be managed as national entities and semi-autonomous entities as well. This will allow them to practice independently and also to serve the population nationally as opposed to regionally. There's also going to be structuring of contracting units for primary healthcare at the district level. And at the moment, there is a proof of concept project for contracting units for primary healthcare, where there is one site in each of the provinces that's being established to really map out the services and to understand the profiles of the populations, to understand the health service delivery platform with public and private sector, including the referral pathways, and to get all the required information to inform contracting. And the information from these proof of concept sites will inform the contract nationally. Then the funds needs to be established, including the governance structures of the fund to enable the different pieces of the Act to be implemented. There's development of a health patient registration system, and I think this has been rolled out throughout the country and is very important so that people can be identified when they present for services. And I think at this point, all citizens or all eligible users of the fund will have a unique identifier. And in time, I think the goal is really to use biometrics as the basis of the system as well. So we know often patients may present without their IDs, or especially in emergencies where it would be very difficult to get an ID or a registration number. And so eventually the system is proposed to run on biometrics. There's also a process of accreditation of service providers where health establishments must be inspected and certified by the Office of Health Standards Compliance, as well as the necessary statutory bodies. So I think for healthcare professionals, for doctors, they would need to be accredited with the HPCSA, and for nurses with the South African Nursing Council and so on. And yeah, I think in terms of facilities, they will need to be certified by the Office of Health Standards Compliance. So I think we spoke about phase one and the purchasing of healthcare services for vulnerable populations. And this includes maternal and child populations, school health services, um, services for the aged, as well as for people with disabilities and rural communities. So this is going to be happening in phase one of ahead of full promulgation of the different areas of the Act. Then I think relevant here would be purchasing of hospital services and other clinical support services by the fund. So this will be an expansion of the personal healthcare services purchased above the primary healthcare platform from higher levels of care, including emergency medical services as well as pathology services. And within this phase, pathology services will be purchased from the NHLS. Okay. Then there's also going to be a need for legislative reforms, and these are some of the different acts that will need to be amended. Okay, so yeah, I think this is where the transition phases will the criteria for what needs to happen in the transition phases ends. And so the next thing I want to talk about is the regulations. So as much as the Act has been assented by the President, the Act provides a framework for the NHI fund and how it will function. But for the detail to be available, there's different regulations that need to be put into place. And currently there's, I think, 25 regulations, as well as provisions for additional regulations that might be needed. But yeah, currently there's 25 regulations that are listed in the Act. And I've listed some of them for you that might be more relevant to the hospital level. Firstly, the legal relationship between the fund and various categories of health establishments and service providers, according to the National Health Act, needs to be defined in the first regulation. Then the payment mechanisms need to be clarified as well. The other regulations deal with the information that needs to be provided to the fund, the clinical information and diagnostic and procedure codes that need to be submitted by the service providers and establishment so that they can be reimbursed, the registration of users, the accreditation and conditional accreditation of healthcare providers and establishments. Then there's also going to need to be regulations on the relationship between the public and private health establishments, the relationship between the fund and medical schemes, and regulations for the development and maintenance of the formulary that looks at the different treatments that will be available. Then there needs to be regulations in terms of the manner in which service providers and health establishments and suppliers must report back to the fund, and all practices that need to be followed as well as the scope and the nature of the services and programs that will be funded. Okay, so I think there's a lot of detail that still needs to be established via the regulations. There will be a lot of committees that are being set up. I'm sure that many people maybe on the call and within the different levels of hospital service delivery will form part of these committees to really come up with the final details and regulations that will guide implementation. And then, yeah, I just thought to summarize, this is very brief, but I thought it might kind of put some perspective for now in the absence of many of the regulations. So when we're looking at the implications in terms of providing universal health coverage via the NHI framework, the coverage is determined by the Act. And so all South African citizens, permanent residents, refugees, inmates, and certain categories of individual foreigners will be eligible for full coverage. and asylum seekers and illegal foreigners will be eligible to emergency medical services as well as notifiable condition services. In terms of the services, there will be a national benefits package and related treatment guidelines. The referral pathways will be very important to enable everybody to have access to the different types of treatment and the different levels of care. And I think within the academic setting, Jarrod did mention earlier that academic hospital is not really a categorization of hospital, but of course, we know many of the hospitals where teaching occurs to be academic hospitals, and I think staff in these hospitals will have roles in teaching, research, as well as the clinical practice. But largely, the teaching and research will fall under the ambit of the employer, which will be the Department of Health. And so the fund will not really have much influence over that. In terms of costs, users will not pay at the point of care. Different hospitals will establish cost centers for managing business activities and determining cost drivers. And I think this will be a change because clinicians usually are not really that involved in financial aspects, but I think many people will develop an understanding of healthcare financing when cost centers are established, especially I think at the managerial level and above. But generally, I think there's going to be a drive towards really being more kind of cognizant of healthcare costs and because there will be incentives related to being more efficient in being cost effective. And then in terms of the funding models, I think the current models being proposed for the hospital levels are global budgets or diagnostic related groups. Okay, so other implications based on what's currently articulated in the Act include ongoing health system strengthening. And I think this is not just because we're moving towards an NHI environment. I think this is something that is inherently important for the health system, as well as quality of services and accreditation criteria. There needs to be a really important move towards improving the health information system. So the health information systems that are available will need to be those that are recommended by the fund or interoperable so that information sharing can happen and inform practice, because we're moving to an outcome-based model of reimbursement. And central hospitals will be regarded as national semi-autonomous entities. There's going to be different reimbursement models that will come into practice, including the establishment of cost centers at the actual hospital level. So yeah, these were just a few thoughts from the Act itself, and I hope it provided some insights into the Act and some of the changes, as well as what it might mean for somebody practicing in a central hospital environment. So yeah, before I stop, I'll just advise everyone to go to the NHI website. You can click on the Department of Health website and there's a link, or you can go directly to it using www.health.gov.za/NHI. I think there's useful information there, and this is the platform that will be regularly updated as with new information. So yeah, with that, I'll hand it back to you, Jarrod.
Thanks so much, Dr. Somaroo. I really appreciate that overview, comprehensive overview of the NHI as a whole. I just want to ask you, so one thing we were wondering about is, obviously you've spoken about central hospitals and the effect the NHI will have there, but in terms of academia, is there any role that the NHI will play? For instance, we in internal medicine have a number of research units that are obviously attached to VITS, but research units do recruit patients from our hospital, from our wards. Is there any role that NHI will play, one, in terms of sort of would the units have to be registered as a practice, or do they form part of the department? And then two, in terms of research funding? Does the NHI play any role there? Just before you answer that, I don't see Mr. Nkosi signed on. If you are signed on, please just raise your hand, then I'll be able to unmute you. But yeah, so that's really the question about academia to start with.
Okay, so yeah, in terms of academia, this will still fall under the ambit of the service provider. Remember, we spoke about the purchaser-provider split. And so the fund will be the purchaser and the provider will be the health system and the different levels of care. And the research falls under that. So the fund will not be directly involved in determining how the research organizations or entities will function. I think the Department of Health will set out the guidelines for that. If there's anything that emerges where it might affect direct patient care, then it will probably need to be considered by the fund as well. Because remember, the fund will only is only responsible for direct patient clinical care and not research. But yeah, but if there are instances where there might be some degree of overlap or additional considerations, I think these should be considered further within the different committees.
Perfect. I'm not sure if this is someone has just commented, I think, or posted a question related to this, saying there are specific requirements to be included met in developing DRGs for academic hospitals. I'm not sure if you can elaborate on that. I'm not too sure what a DRG is either.
Okay. So a DRG is a diagnostic related group. So essentially, let's take a cesarean section. Instead of paying for the different items that are used to perform a cesarean section or the healthcare workers, as well as the indirect hospital costs that are involved with this each time on a fee-for-service basis, different conditions are going to be costed ahead of time. And if somebody undergoes a certain procedure, the payment will be what's fixed for that specific diagnostic related group. So I think there is work going on in terms of this for the country. These costs will also include considerations for variability, because sometimes you may get a standard uncomplicated procedure and sometimes you may get a complicated procedure. So I think all of this will be factored in, and one cost determined for the procedure. And I think what's important for this is, one, for the health information systems to be very operational, very I think defined and available. And also I think that so right now the teams that are working on the DRGs are considering where there's some packages available from other countries, or there's an opportunity to actually develop these for the South African context as well. So I think the teams that are working on this are deliberating on the two. But at the end of the day, we need to kind of implement the system that is most relevant for our context, considering the variability as much as the time that it will take for all facilities to be at the same level.
Thank you.
Okay.
Dr. Siva has just commented on there as well. This is to reflect the mix of service/research, which often takes place contiguously in a patient in an academic hospital. The teaching cost must also be included in an academic DRG. The NHI Act refers to payments by way of DRG. So thank you, Dr. Siva, I hope I'm pronouncing your name right, for that insight there. Just the next question, which I think is very relevant, we've certainly seen it in our hospital in terms of difficulty in appointing registrars, difficulty in appointing fellows, difficulty in appointing specialists and consultants. in terms of, I mean, one is HR related issues, but two is just in terms of funding and, freezing posts here and there. But Professor Paget has just commented here, one of the most concerning aspects of NHI is that we have not seen any real attempt to increase healthcare capacity. In fact, the government has limited training and limited licensing of healthcare facilities. Our central hospitals require many billions of rand to achieve acceptable standards to a population that will now be paying for services, paying in inverted commas. The private sector is already battling with capacity. So while NHI sounds nice, how will we do this with the small tax base we will have by 2028?
Okay, so yeah, I think, the journey to actually decide on NHI as the means to reform healthcare spending has happened over many years. As much as the Green Paper for NHI was introduced in 2011, I think the discussions probably started even pre-1994 when the country was really moving toward the democratic dispensation. And yeah, I think the different health systems needed to be integrated. And so, yeah, I think these discussions have happened over time. And at this point, the decision taken by the government is that the NHI-based framework is the most appropriate for our context in South Africa to actually achieve better health outcomes for the population. And I think as much as there are concerns, for example, I'm just going to look at Dr. Paget's comment quickly.
Sorry, it'll be in the answered section if you can see it in the Q&A.
Right. Okay, thanks, Jarrod. So yeah, I mean, there's definitely constraints within the public sector and there's constraints within the private sector. And if we continue what we're doing now, these constraints will not change. We have to have some strategy to improve things. And what NHI hopes to achieve is really to extend the service delivery platform for all South Africans to, if you look at the healthcare spending at the moment, when I think the actuaries and economists really crunch the numbers, they have just shown that there is enough healthcare spending in the country to actually address population health in a better way. But it's majority of the spending currently is concentrated in the private sector, which is at this point in time responsible for care of about 14% of the population. So within the South African context, we have majority of the population depending on a service that's really works really well in some places, but the services are incredibly variable and we know what the challenges with quality are. So by opening up the service delivery platform to include both the public and the private sector, there's going to be a decrease on the current strain on the public sector, and the private sector that has more healthcare workers employed will probably be able to better manage some of the numbers. But obviously, it's an iterative process where the different sectors need to work together. In time, hopefully, the health systems will be more integrated and the referral pathways will be more established so that the country works, the healthcare system of the country works together. I think, yeah, each service provider, for example, a central hospital and a private hospital down the road, will be providing services for the same population. So I think right now, if you won't, hopefully some of the patients who are in the long queues at Shala Mateke will be able to access services at Moore Park Hospital or another hospital because it will be paid for. Right now, they would not be able to afford it. But hopefully, in terms of the resource distribution and access for patients, hopefully that will improve the system as a starting point. And in terms of the improving the efficiencies in spending and how we practice, I mean, this is something that needs to happen continually over time. It has had to happen in the past, and in certain places it's been done well, in certain places it has not been done well. And I think it has to be a common goal, really. Yeah, and I don't think, I mean, it's proposed to achieve phase 1 of the transitional phase by 2028. But I think if you look at the practicalities of implementing the Act, first, you need to have the regulations put into place. Then they need to go to Parliament for comment. And after that, can it be promulgated? So, yeah, I mean, if we look at the number of regulations that really need to be put into place, the timelines are likely to take longer than envisaged for a lot of the regulations, maybe not all. But yeah, I don't think that we're bound to the timelines in the Act. These were proposed by the people who wrote the Act with the different modeling that was done previously. But yeah, as we go forward, we'll see how the timelines will happen. And personally, I think it might take longer. Okay.
Thanks. I'm cognizant of time. It's 10 to 9, but I think we have a good amount of time. I'll post the CP link and shortly if people do want to stay on after 9, if you're happy to stay on, Dr. Somaroo. I want to just, there's 4 questions, and I want to focus just on Professor Lowe. Has posted one in the Q&A, Professor Lowe from UCT. The first one he's asked is, if tertiary hospitals will function semi-autonomously, will they tender for procurement for equipment, drugs, and services, or will that be centralized? And then he has then just said as a second thing, will the capitation model be adjusted for individual central hospitals providing specialized quaternary services, for example, transplantation, that might not be available in all central hospitals, e.g. when patients are referred for stem cell transplantation from one central hospital to another. Sorry, those are 2 very separate things. But just maybe to start on the procurement of tertiary hospitals, whether it's autonomous or centralized.
Okay, great. So in terms of the procurement for equipment, drugs, and services, I don't think hospitals will tender independently, but so those processes still need to be defined by regulation yet. I think, yeah, so we can't actually know what will be decided, but there are different considerations. In terms of the capitation model, so central hospitals won't be paid by capitation. The capitation model, which is funding for populations, will be at the primary healthcare level. The different models being considered for the central hospitals will be the DRG, and for the very specialized services, the global budget, which is kind of similar to the DRG model, but I think it's prospective budgeting for the different services that will be provided, like transplantation. So, but here as well, I think, as much as we have the principles in place and the different models that are proposed, the detail is not available yet, and the detail will be determined in the regulation. Okay.
And then I think just kind of the last sort of 2 questions that are there, they do kind of link together. And Dr. Gardner, I haven't ignored your question for all this time, but I'm going to link them together. So Dr. Naidu, who's one of our consultants here, said, is state not already essentially universal healthcare? Both patients with and without medical aid can access health facilities. Why is the money and resources being used to fund NHI not being used to improve state sector to be at the same level, if not better than private? Then patients won't need to go to private to access good healthcare. And sort of Dr. Gardner has similar things saying, why not concentrate on the present issues, wasteful expenditure that we know about, 1.1 billion rand, Gauteng Health wasteful expenditure this year. Why not focus on that? And I quite like his last line there. If the wineskin leaks, why put more wine in it?
Sure. Okay, so
I must say, Dr. Somaroo, I'm sorry, I know Mr. Nkosi was meant to be signed on with you to answer a couple of these questions. So thank you for answering.
That's fine. I think he must have been held up. He is the chief director, so I think, he usually can be called up at short notice. But yeah, so I think, the issue of corruption has been pervasive in the health system. I think it's very explicit in the public health system, and to a much, could be smaller degree, but it is implicit in private healthcare as well. And think with a certain awareness of how the funds flow at the moment, currently funds flow from Treasury to the Department of Health, and then to the provinces, and then to the districts, and then to the hospitals. So there's a lot of pathways in this process, and there's a lot of places for risk. With the NHI fund, I think that the risk for corruption will be much less. One, because it's going to be a semi-autonomous entity, and two, because the funds are going to flow from the fund directly to the service provider. And so hopefully that will help. There's also going to be a risk management directorate within the NHI fund, because we know within our context, this has been a pervasive problem over the years. And so hopefully this will improve corruption as we see it. But I mean, there is always implicit corruption. And so we've got to be very aware, and we've got to really put strong preventative measures in place. And if it's missed, we've got to have measures in place to detect for early warning signs. And I think hopefully we will have an engaged citizenship, and the people will be accountable, and that corruption will be addressed much better than it has been in the past. And then in terms of universal health coverage, so in essence, in principle, yes, we provide universal health care in that everybody has access to state facilities. But if you consider our context, if you consider the maldistribution of resources within the public and private sector, I think with doctors, it's over 70% of doctors who work in the private sector and are caring for 14% of the population. We need to improve access to more of the population to the healthcare workers throughout the country. So that means in the private sector, specifically in our context. If we had an equal system where the numbers were equal, the funding was equal, then we could say, yes, we have functional universal health coverage. But now we only have it in principle, not in practice. And so the hope of this reform is really to improve actual access to healthcare to all people so that we can improve health outcomes. If we improve, I think this question certainly would have been asked, why is the money and resources to fund the NHI not being used to improve the state only? And that's because of the system that we find ourselves in. To do that would not achieve that outcome. We need a different type of reform compared to other countries, just based on the context that we find ourselves in. So, yeah, I hope that answers that.
I'm going to play devil's advocate to you there and just respond saying, I think we, obviously, as you say, 70% of doctors are in private, but from my own experience, colleagues of mine that I finished registrar time with that, I currently, when I do my RWAPs, I see in private practice, I'd say, this is anecdotal, so don't quote me on a study here, but I'd say 60 to 70% of them would love to come back to state, but the posts simply don't exist.
Right.
We look at one of our divisions here, used to have 10 consultants, now is down to 2 consultants and 2 fellows. So is the issue in terms of funding, making it equitable for everyone, or is it not just that we need to get more doctors into state practice? And obviously we've seen the media in the last week and what things happened over the weekend. And if we have registrars, and there's obviously people on the call from Barra, where there are tons of patients, and I mean, as a registrar you manage 30 to 40 patients, because that's the patient load that you have to deal with. So is it not a better system to focus on funding more registrar posts, more people to train these registrars, so more specialists, and I'm talking specifically central and tertiary hospitals, than focusing on spreading out healthcare across, all 2 systems that become one?
Okay, no, I do hear you. And so the question there is about funding. Right now, where will that extra funding come from if we're already short of funding within the public healthcare sector? And certainly, I think there's been healthcare strengthening initiatives over the past few decades to try to address things. And in some instances, it's improved, and in some instances, things have gotten worse. But there certainly have been attempts. And I mean, I know now there's a lot of issues with posts, there's a lot of issues with quality of care, but to have the amount of funding that you will need to improve that over the next few years, let's say over the next 20 years, is not easily available to us as a country. We see the inequitable distribution of funds within the public and private healthcare sectors. And so what we need to do is really use the funds in a more efficient manner. And we can't just say we'll stop medical aid tax credits and we'll stop other incentives for privately funded patients and then just redirect that money to public healthcare facilities, because some of the root causes of the problem will still be there. I think a lot of these different options have been considered over the years, and they've probably been deliberated more in much detail, and especially from an economic perspective. I think this has been selected as the most appropriate solution for our country at this point. So, yeah.
Perfect, thank you. I think it's on 9 o'clock. I want to just finish off with one question. Two people have posted a question that we can link together, and so someone,
Okay.
let me start. Professor Lowe has said, if there is time, if there's time for one question, there is. How will the allocation of patients to doctors currently in private be agreed upon? Will patients have a choice who they want to go to if it is not fee for service? And that links in with someone anonymous has posted, is it fair to say that public hospitals and health professionals who've chosen to remain in public will be competing with private hospitals in a sense as providers? These public institutes have been constantly underfunded by the DOH and are now in a sense being abandoned by the state in favor of private institutes. So I think to link those two together, a patient in the queue at Charlotte, how will they get into the queue at Mill Park, with its reputation, versus, am I going to be competing to get my patients back into my clinic here at Charlotte?
Sure. So, like I said, the regulations still have to be written, but as I understand it now, a patient will register at a primary healthcare provider. So they have a choice of who they register with. They'll also be able to register with a second provider. Sometimes somebody may work away from where they live, and so it won't make practical sense for them to go back home. Maybe they travel on weekends or travel less regularly to their home. So they would need to register with a second primary healthcare provider. And the secondary level of service that they receive, or tertiary level, will depend on the referral pathways linked to that provider. So it really is going to be mapped out for the different geographic areas of the country. So I think at the higher levels, there will be less direct choice, but patients will have a choice really in terms of where they register for the primary healthcare providers. So indirectly, they have a choice. Okay.
Thank you so much. I hope that's given everyone a bit of insight into sort of where we are. There's obviously a lot of opinions, a lot of feelings, a lot of emotions around NHI. Dr. Somaroo, thank you for joining us. I know it can't be easy talking about this with the sort of sentiment around NHI, but we appreciate the time you've taken and just putting that together, that talk for us. If there are no further questions, the CPD link has been posted in the chat a few times, so please click on that. Please don't post your name and MP number in the chat. You're not going to get CPD that way. And then I'll just see if Dr. Somaroo, if you want to say anything in closing.
Yeah, sure. No, thanks, Jarrod. Thanks for the invitation and for the discussion. And like you said, there's a lot of varying opinions, and we come from different backgrounds, and there's going to be different changes for different individuals as we move forward as well. But I think it's important to engage on continual conversations, be they difficult or easier. Hopefully they will become easier as time goes on. But it's really important to keep engaged, because at the end of the day, we all have the same goal, is to improve health outcomes for more people. And yeah, so thanks for the invitation to the branch, and yeah, all the best.
Thank you. Thanks so much. Thanks everyone for joining us. CPD link is in the chat. Just again, if you post your name and MP number in the chat, you will not get CPD points. So click on the link. I will leave the meeting running for the next 5-10 minutes just to give everyone a chance to click on that link. Otherwise, please have an excellent weekend, an excellent Friday, and we'll see you all next week in person and or online for a meeting by cardiology. Thanks, everyone, and thanks, Dr. Somaroo.
Thanks, Jarrod. Bye, everyone.